has ended, and if it was pre-gestational diabetes, we would have some abnormal values at this time.
Yes, I mean, patient who develop gestational diabetes should have a glucose tolerance at the end of puerperium, which is at 6 weeks. And so if the glucose tolerance is normal, then this is a gestational diabetes. If it is abnormal, then that could be pre-existing gestational diabetes. And the other thing, which is really important, that the patient who develop gestational diabetes, they are at risk of developing a chronic type of diabetes. Yes?
There is a 15 to 30% chance to develop a diabetes in the future. صحيح؟
Yes, هي بتقدرش تقولي 15 to 30 only. It is roughly the risk is 1 to 2% per year. So 1 to 2% per year. So if the patient is suppose like your patient, she is 36 years and she developed the gestational age at 36 weeks. So at the age of 60, like that's 24 years later, this patient would have a chance of around 25 to 50% chance of being diabetic at the age of 60. If she developed it like at 25 years of age, then at the age of 50, she would have probably up to 50% chance of being diabetic at that stage. So the risk is 1 to 2% per year after the diagnosis of gestational diabetes. Now, this is really very important because when you counsel the patient about this risk and you tell them that you have this chance, like 50% chance of developing diabetes at the age of 50, unless you do something about it. Now, this is an important way to advise regarding lifestyle modification, exercise, weight reduction. All these can reduce the chance of developing diabetes in the future. So, and if you can look at it as pregnancy is being a test for your potential of developing diabetes in the future. If you pass the pregnancy without developing gestational diabetes, this means that your body is somewhat resistant to developing diabetes in the future. So it is a stress. It's viewed as glucose tolerance. You can view pregnancy as a glucose tolerance test for your body. Is that clear؟
نعم دكتور.
واضحة يعني البريجنانسي ممكن تتفكر فيه انه as a challenge to your body. So a patient who pass the pregnancy and they can accommodate the diabetogenic changes that happen in pregnancy, it's like giving them glucose load. So it's like a challenge test for your future development of gestational diabetes, for future development of chronic type of diabetes. So you can view it in this way. Okay.
تمام دكتور. أنا هيك كملت، إذا بتحب تزيد أي شيء.
So you've just talked about gestational diabetes and
we talked about risk factors. We discussed the screening and diagnosis and management during pregnancy and postpartum.
This is really was good. Thank you, يا هلا. يعطيك العافية علي. So as you mentioned, the assessment starts right from the beginning, and your chance is what we call the booking visit. So the early visit, the first visit, is what we call it the booking visit. So that is the first, and the first visit, which is the booking, is the visit where you do a detailed assessment of this pregnancy. So you take the complete history, the current past obstetric, family, social, drugs, and so on. So you take a detailed history. Again, you do a detailed examination, and based on the risk factors, you would decide as with regard to diabetes. So in the first visit, you classify patient into low risk or high risk group. اللي هم high risk group are those with risk factors. So patient with risk factors, you do glucose screening at the booking, and if it is negative, you repeat it at the 24, 28 weeks. Patient who are low risk, you can do it routinely at 24 to 28 weeks. Now, adding to the risk factors that you've mentioned, اللي هم الage, high age, high parity, family history, body mass index, and past obstetric risk factors, including patient with macrosomic babies in the previous pregnancies, sudden or intrauterine fetal death in the previous pregnancies, previous history of polyhydramnios. All these are risk factors. Now, from gynecological point of view, there's one risk factors that you need to pay attention. Patients who are known to have polycystic ovarian disease, PCOS, especially those who get pregnant with the induction of ovulation or assisted pregnancies. Those are at high risk group, and therefore patients who are known to have PCOS should have screening at the early booking visit, and if it's negative, you have to repeat it at 24, 28 weeks. Now, if they get pregnant while they are taking metformin أو الجلوكوفيج يعني الناس بتعرفه, they can continue using that medication throughout pregnancy, and it has been shown to be effective in controlling the blood sugar, as well as it reduces the risk of miscarriage, which is associated with the polycystic ovarian disease. Now, if they are diagnosed, then at 24, 28 weeks, you diagnose them with gestational diabetes, or in that case, there are the management consists of controlling the blood sugar, as you mentioned, by diet, then by insulin or medication. And the other thing is try to look for fetal complications. So they will need frequent assessment for the fetal well-being, fetal weight, polyhydramnios, and potential complications associated with macrosomia and polyhydramnios. Those patients might be at risk of preterm labor, premature rupture of membrane. They are more prone to have recurrent candidal infection or urinary tract infection. So you have to have a regular assessment and looking for these complications, plus the monitoring of the fetal well-being and growth. And if there are any signs of polyhydramnios or macrosomia, that will indicate a poor control of their gestational diabetes. In the latest weeks of pregnancy, after 32, 34 weeks, they need intensive monitoring of the fetal well-being. So those patients will be regarded as high-risk pregnancy, and they have to be seen more frequently, especially in the last trimester. They should be seen once to twice per week, and they will have to have the fetal assessment once to twice per week until you decide on the delivery at 38 weeks. Now, if those patients develop threatened preterm labor, or they are at risk of preterm labor prematurely, then of course, as you know, you might need to give them steroids, dexamethasone, to enhance the lung maturity. Now, in this case, pay attention that the dexamethasone or betamethasone might cause high blood sugar, so it will affect the glucose control, and therefore these patients should be in hospital. They will be maintained on the same medication for diabetes. They are given the steroid, and at the same time, they will need an extra doses of insulin to maintain the control of diabetes during this period. So ideally, those patients will be admitted for like 2 to 3 days after the dexamethasone, and they will receive their insulin, a regular insulin تاعهم, plus they will be put on what we call it the sliding scale, which you tighter the dose of insulin, or you give them an extra doses of insulin to make sure that the blood sugar is within the normal control. Now, antenatally, your target blood sugar should be something between 4 and 8 millimoles. Yani, for fasting, and maximum postprandial should not be more than 8 millimoles, اللي هو تقريبا 140 راح يكون. So that's your target. Now, once they are in labor, you need even more. If they go into vaginal delivery, you need even higher or a tighter control. So your target will be something between 3 and 7 millimoles. And the worst thing that can happen to a diabetic patient during pregnancy is the fluctuation in blood sugar, periods of hypoglycemia and hyperglycemia, hyperglycemia. This is the worst scenario that can happen to diabetic patients. So you need to maintain the blood sugar at constant level. So even if it is into the hyperglycemic side, it's much better than the fluctuation. The fluctuation are the worst scenario. Okay. واضح؟
واضح دكتور.
So you try to keep a steady level of blood sugar. يعني مش خط تقريبا، بس يعني ال fluctuation are minimal. Even if it is in the hyperglycemic side. So that's not a problem. What you need really to avoid is the fluctuation in the blood sugar, with patient going into periods of hyperglycemia followed by periods of hypoglycemia and so on. This is really bad during the control. Now, during delivery, you need a tighter control, and usually what we use the patient will be fasting from the day in the morning. We stop the morning dose of insulin. We put them in what we call the GKI infusion, which is glucose infusion, زائد potassium and insulin infusion in the other hand. So you give them a steady rate of glucose, and then in the other hand, you give them insulin and glucose, and you vary the dose of insulin according to the blood sugar. So patient will be admitted, they will have 2 drips. One is glucose with potassium and the other with insulin. So you give them the glucose at steady rate. لازم تثبت واحد منهم الريت، مثلا تقول 120 ml per hour. On the other hand, you give them insulin infusion, and you measure the blood sugar every hour by dipstick, by glucocheck. And then you can increase the dose and you decrease the dose of insulin infusion according to the blood sugar. Now, immediately after delivery, تقريبا the dose requirement from insulin will be reduced by half immediately. Once you deliver the placenta, their insulin requirement will drop by 50%. And therefore, if depending on the mode of delivery, whether vaginal or cesarean, so the next dose will be half the dose which they require during pregnancy. And after that, you start monitoring the blood sugar, and you might eventually have to stop the insulin if the blood sugars are improved. So this is generally the outline how you manage gestational diabetes during pregnancy. Do you have any questions?
دكتور، بالنسبة للدايت ثيرابي، كم نعطي المهلة المريضة أنها تستمر على الدايت ثيرابي قبل ما نبلشها على الميديكال مانجمنت؟ ولا يعني أول ما يصير عندها abnormal value على طول بنعطيها الأنسولين أو الميتفورمين وهيك؟
زي ما حكيت لك يا هلا، صح؟ مظبوط هلا؟
هلا.
زي ما حكيت لك، البيشنت اللي عندهم impaired GTT اللي هم you have abnormal fasting but the 2 hours is normal or vice versa, اللي هم they are not meeting the criteria of diabetes. Those patients usually will benefit from diet and exercise. And of course, you do this and you continue glucose monitoring, as you mentioned in your slide. Now, if the glucose values become higher and they go into the diabetic range, يعني صارت true gestational diabetes, usually diet alone is not enough. You need to add medical therapy. You can start by oral, يعني metformin, and you see the control. If the control is not maintained by metformin, then you add insulin, or you can shift them into insulin. Usually what we do now is we add insulin to the metformin, because metformin, in other words, they call it insulin sensitizer. So it increases the effect of insulin, and therefore you will need a smaller doses of insulin to achieve the control.
تمام، شكرا دكتور.
Okay, so diet on the pre-diabetic state. Once they are diabetic, then you need to initiate metformin. Continue monitoring. If that is not achieving a control, you add insulin, starting from the smallest dose. With the continuous monitoring, you might need to adjust the dose by increasing it or decreasing it, depending on the values. Okay. Now, as regard to the fetal complication, I just want to draw your attention that gestational diabetes differ from chronic diabetes on only one thing. The chronic diabetes management is the same. The only thing here is that patient who develop gestational diabetes, the baby is not at risk of congenital abnormalities. لأنه this gestational diabetes usually develop after the embryogenesis period, so it's unlikely to affect the development of the baby. So the risk of congenital abnormality in patient with gestational diabetes is similar to the general population. However, patients who enter the pregnancy with diabetes, اللي هم مسميهم chronic diabetes, the risk of congenital abnormality of the fetus is almost 4 times that of the general population. هاي واضحة المعلومة؟
واضحة دكتور.
Now the other aspect which is different in the management between chronic diabetes and gestational diabetes, the patient اللي عندهم chronic diabetes during pregnancy, there is one additional thing here that you need to look, is that you do regular assessment for potential complication of diabetes on the mother, like retinopathy, nephropathy, vasculopathy. So those patients is لأنه عندهم chronic diabetes, these complication needs time, so they are unlikely to develop during gestational diabetes, but they are likely to develop in patients with chronic diabetes. فهذول recommendation تاعهم إنه you have to do a frequent assessment of for nephropathy, so you do urine analysis and culture, looking for proteinuria in particular, and if there's a proteinuria, then you can look for creatinine protein ratio in the urine. These patients are recommended that they will have to have ophthalmoscopy or fundoscopy once in each trimester, so 3 times at the booking, and the second trimester, and once in the 3rd trimester. Plus if there are any evidence of vasculopathy, then they have to have a regular assessment for that. Okay. Any questions? حد عنده أي سؤال؟
يعطيك العافية دكتور.
يعطيك العافية دكتور، أظن واضح.
في أسئلة أخرى على الموضوع؟ No questions?
أظن واضح دكتور.
What else?
دكتور
Yes.
صوتك مش طالع، حكيتي شيء.
Yes. What else بحكي what else?
دكتور مثلا ممكن لما يكون بالبيشنتس اللي اصلا عندهم هم دي ام، هل ننصحهم انه اصلا يكون عندهم النمبر اوف بريجننسيز اقل؟ هل هذا بيأثر ولا ما له تأثير؟
اوكي. هذول المرضى، نشوف المرضى اللي عندهم chronic diabetes ideally they should be seen in the pre-pregnancy counseling clinic. يعني انت بتشوفهم في عيادة قبل pregnancy. If they are planning for pregnancy you see them in the pre-pregnancy counseling clinic اللي بنسميها. ايش الهدف من pre-pregnancy counseling clinic؟ اول شيء الاسسمنت، انك اساس تعمل اسسمنت للدايابيتس وتشوف البوتنشال كومبليكيشنز اللي موجوده عند المريضه. يعني you assess their blood sugar, you assess their hemoglobin A1C, and you assess them for potential complication like nephropathy, retinopathy, and so on. Now, if the blood glucose, وخصوصا الهيموجلوبين A1C is high, you advise them against pregnancy until it's controlled. وبتعرفوا انتوا الكنترول راح يحتاج minimum 3 months or more. So those patients should be controlled very well to maintain a hemoglobin A1C below 6.5 قبل ما you allow them to get pregnant. Now, if there are any complications of diabetes like nephropathy and retinopathy, then you optimize the treatment before pregnancy. بنشافوا بأطباء العيون، أطباء الكلى and so on, and you counsel them that nephropathy and retinopathy of diabetes usually tend to get worse during pregnancy. So they might be at risk of losing their vision. They might be at risk of going into renal failure and so on. So you give them all these assessment and counseling. Now, if the pregnancy plus they have to receive folic acid 5 milligram daily for 3 months before contemplating pregnancy. So that's the aim of the pregnancy counseling clinic. Now, if those patients is the hemoglobin A1C is controlled and they receive the folic acid, then they can go into try for pregnancy. طبعا ما في limitation على النمبر، له علاقة في كيف وضع الديابيتس عندهم، هل في complications أو ما في complications، أكثر من إنه عدد معين يعني 1 ولا 2. فهو إذا الديابيتس is well controlled وما في أي مشاكل they achieve the pre-pregnancy counseling clinic, they attended, it has been optimizing of their management. Now that reduce the complication during pregnancy, and in particular congenital abnormalities. Congenital abnormalities حكينا احنا في chronic diabetes is 4 times that of the general population. لكن إذا عندك مريضة أنت شفتها في pre-pregnancy counseling clinic or you give them folic acid or they enter the pregnancy with well-controlled diabetes, then you significantly reduce their risk of congenital abnormality. ممكن تنزل حتى ال risk of congenital abnormality as low as the general population. And this is why it's really very important and critical in advising these patients to attend the pre-pregnancy counseling clinic. Okay?
دكتور.
Now, if if they decided against pregnancy يعني إذا إنه كان الوضع لا يسمح في البريجنانسي they have retinopathy or nephropathy or you decided to defer لأنه الهيموغلوبين A1C is not controlled بدك شوية وقت على أساس to control it. It's really very important again to advise them to use a reliable method of contraception. يعني they have to use a very reliable method of contraception during this period.
تمام، شكرا دكتور.
عفوا. حد عنده أي سؤال آخر؟
دكتور حابب أسألك لو سمحت إنه في أني possibility يمكن مش logical السؤال إنه البيبي to develop diabetes يعني من هاي الموضوع gestation الأول أو having uncontrolled يعني chronic diabetes. Thank you.
Okay. لا هو theoretically لا يعني أنت بالعكس الجلوكوز إذا المريضة عندها ديابيتس فالبلد شوجر تاعها راح يكون عالي. Now glucose flow freely through the placenta, so it will go into the baby. As a result, the baby will have hyperglycemia. To control the blood sugar in the baby راح يصير عندك high insulin secretion in the fetus, and that high insulin secretion will bring the blood sugar down to normal. Now, after delivery, because those patients have high insulin level, they are at risk of developing hypoglycemia. So, the babies immediately after delivery are at risk of developing hypoglycemia. لأنه they have high insulin secretion. The basal insulin secretion is very high. والinsulin has, والglucose has been cut off from الأم. لسبب هذول the babies of infant of diabetic mother, they are kept in the nursery or in the neonatal unit with frequent feeding, frequent checking of blood sugar, especially in the first 48 hours, to make sure that they don't go into hypoglycemia. Are they at risk of diabetes long term? No, they are not in particular.
يس دكتور هلا أنا قرأت إنه البلاسينتا produce يعني anti insulin factors، فمن هاي الطريقة ممكن هدول الفاكتورز يعني يروح عند البيبي يعملوا insulin resistance، وبالتالي يعني فرضيا بس كنت بفكر بهاي الطريقة بس يعني
No, these are almost are proteins which are usually anti-insulin factors اللي هم predisposed to insulin resistance. They are temporary and they are degraded. So they are not. بس هو الميثود of inheritance يعني أو type 2 diabetes بتعرف إنه في an element of familial predisposition. So this baby might be chronically at risk of developing diabetes for another reason, not that they are born to a diabetic mother or events during pregnancy.
Yes, understood.
Yeah.
Thank you.
Okay. أي أسئلة ثانية على هذا الموضوع أو أي موضوع آخر؟ هاي شباب.
هلا دكتور، كمان سؤال لو سمحت. يعني عشان البيبيز هدول ممكن في ريسك انهم يجوا ماكروسومي، يعني بيج بيبيز، فهل الاهل يعني عندهم استيعاب انه ممكن يصير كومبليكيشن مثلا زي الشولدر ديستوشيا؟ وايش الامبليكيشن، يعني ايش ممكن يعملوا الاهل عشان يعني لو بيعرفوا انه البيبي تاعهم راح يجي هيك؟
هو أنت what you do, this is part of your assessment now. When you are close to the timing of delivery, مثلا زي ما حكينا 37-38 weeks, you have now to come to term about the delivery. And the decision, the timing of the delivery حكينا عنه, it's usually we would deliver them at 38 weeks. بالنسبة للكرونيك دايابيتس، بالنسبة للجستيشنال دايابيتس، يعني أنا بالنسبة لهلا اللي حكته، بالنسبة للجستيشنال دايابيتس إذا it's very well controlled diabetes وجستيشنال, there is no problem of keeping them until 39 weeks. But for chronic diabetes, no, it's 38 weeks. So chronic diabetes, you deliver them at 38 weeks. Uncontrolled gestational diabetes, you deliver them at 38 weeks. Very well controlled gestational diabetes, you can reach 39 weeks. At the time, so that's the timing. Now, you discuss the mode of delivery. Now, the mode of delivery, whether cesarean or vaginal, will depend on the parameters and different parameters. One of them, the most important of them, is the estimated fetal weight. If the estimated fetal weight at the timing of delivery, at 38 weeks, is more than 4 kilograms, then we would recommend delivery by cesarean section. أقل من 38 weeks, أقل من 4 kilograms وما في أي complication, then we can attempt vaginal delivery, provided there is no other obstetric indication for cesarean section. Of course, it's all to do with the counseling, putting the patient and her family in the picture, risk of shoulder dystocia, risk of birth trauma to the baby, Erb's palsy, plus the risk of birth trauma to the mother, including vaginal tears, cervical laceration, and so on. ما بعرف إذا جاوبتك هيك.
Yes, understood. كان يعني سؤالي عن يعني الكونسلنج mainly مع الأهل. Yes.
It has to be counseling. يعني you have to put them on the picture اللي هم إيش potential complication during labor, during delivery, and you guide them to choose the best mode of delivery for that particular patient.
Yes, doctor.
Okay. Anything else? Do we need to go into a third session ولا اكتفيتوا؟ لأنه باقي معنا 4 دقائق بس.
أظن دكتور كافي يعني what we discussed.
ترجع للنوم، تكملوا نومتكم. أنا بصحيكوا بكير يعني.
دكتور، يمكن في هدول ال 2 minutes بدي أحكي كمان سؤال. مثلا يعني إذا كان any patient with يعني combined other conditions مثل hypertension, patients with مثلا Cushing syndrome, في any مثلا specific يعني special management لهم ولا بنعملهم نفس الشيء؟ يعني في any consideration لهم؟
لا طبعا في، يعني الاسسمنت is complete during pregnancy. يعني البيشنت اللي they develop مثلا pre-eclampsia, patient with diabetes or gestational diabetes, they are at risk of developing pre-eclampsia. So if they develop pre-eclampsia, becoming a severe type of pre-eclampsia, you might need to deliver them earlier than this. You might have to deliver them prematurely at 34, 38 weeks. So it's all combined. I mean, you look at the patient as a whole. احنا هون كنا بنناقش بس from pure gestational diabetes, but if there are any other complications, of course they have to come into the equation when you decide when and how to deliver the baby. So if the patient developed, for example, severe preeclampsia وصار عندها +3 +4 protein, high blood pressure at 34 weeks, of course you have to deliver here.
يس دكتور، يعني بالتالي إذا كان عندها chronic diabetes وكان في عند البيبي congenital anomaly، فبالتالي ممكن الريسك إنه to live with this يعني problem يعني بيكون أعلى لو كان يعني لو اضطر الدكتور يعني to deliver her، ولا مش بالضرورة؟
congenital abnormalities، لا congenital abnormalities usually ما لهم يعني effect على التايمينج، لأنه معظمهم are cardiac or neural tube defects. والكاردياك بالعكس البيبي as long as the baby is inside there is no risk of death. يعني بالعكس أنت كل ما طولت الحمل at the time of delivery if you need any surgical intervention للفيتس بكون أحسن، لأنه بكون ماتشور ووزنه صار أحسن وكان tolerate surgery. فcongenital abnormality لحالها لوحدها ما بتحدد إنه the timing of delivery. بس concomitant medical disorders أو concomitant complication on the mother, yes, it can affect the timing of the delivery. Okay?
Understood.
ماشي يا شباب، إذا ما في أي أسئلة ثانية وما بدكم سيشن ثالثة I can leave you now.
تمام، يعطيك العافية دكتور، شكرا
يعطيكم
جزيلا.
العافية جميعا. هلا فيكم.